Good afternoon, everyone. Thank you for joining us today for what is the last event from our series of paediatric webinars. What I'd like to do is, first of all, in relation to the event, to let you go through and to tell you what's going to happen. Obviously, I will do a very quick introduction, introduce Max and introduce Ineg if you haven't come across us before. Max will provide us with his slides, and we're very, very grateful to have him here today. I will introduce him fully in a moment. And following that, there will be a Q&A. We do want to hear from you following the presentation. And so please provide your questions in the top in either the chat or the Q&A function. So just very quickly, Ineg, who we are. You may not have come across us before, but we are the specialists which help you accelerate your claim life cycle and reduce unrecoverable costs. Very interesting point is we've literally just relaunched our new branding, and on our website you will be able to find a search tool which allows you to search through the different types of experts that we hold on our database, allowing you to find out who we might have before you reach out to us. That aside, we are delighted to welcome Mr. Max Mifsud today. He is a consultant orthopaedic surgeon at Nuffield in Oxford, and he specialises in managing the complex paediatric trauma. I'm not going to go into too much details because I might be spoiling his presentation. And just to let you know as well, unfortunately, Mr. Mifsud does have an emergency works going on in his house currently today, which was unexpected. So he may have to take a short recess in the middle if something pops up. But without further ado, please, I'm delighted to introduce you to Mr. Max Mifsud, who will be presenting today.
Thank you very much, Leo, and thank you all for joining. Yes, firstly, if I do need to nip out for a couple of minutes, I do apologise. Hopefully not. Right, so the topic for today is medico-legal aspects of growth plate injuries. And we'll talk through a bit about the growth plate because it's a fairly nuanced bit about pediatric trauma, and talk about some cases as well. So as I said, yeah, the aim, we'll talk a bit about the growth plate, we'll talk a bit about the legal aspects of how injuries to the growth plate can result in long-term sequelae, and therefore where you get involved in it, as I said, we'll talk through some cases and questions. So first of all, what is the growth plate? So unlike the bones of, I presume, everyone on this chat, where we are all skeletally mature, our bones don't grow. They can heal if we have a fracture, but they don't grow. They don't change neither in length nor in shape otherwise. Children's bones do. So you can see here on the slide, there's a line through the bone there, there's another one there, and there's another one there, and that's called the growth plate. So that's where the bone not only gets longer, but gets bigger as a child grows. It is a relative area of weakness and therefore is susceptible to injury specific to the growth plate. We know that growth plate injuries are very common because children commonly injure themselves. It is not uncommon for the growth plates to be injured, and about 15% of fractures in those under the age of 16 will involve to some degree the growth plate. Now, very few children who have injuries to the growth plate end up having problems in the future, but it is those in whom the growth plate has been affected that we need to keep a close eye on them. Boys typically are much more likely to get injured than girls because they tend to be naughtier and have a higher participation in contact sports as well, and risk-taking behavior in general. There are some sites which are more common. So firstly, the hands and the fingers, but also what's known as the distal radius or the wrist, and the distal tibia, which is the ankle. They are the most common sites. So I say wrist and ankle are probably the most common. Injuries in the bottom end of your thigh bone, so just above your knee and what's known as your distal femur, they are rarer, but they are the ones most susceptible to having what's called a growth arrest, and we'll talk a bit about that. The various growth plates in all the body, and the reason this is important is because different parts of the growth plate, different growth plates contribute different amounts to the actual growth of the limb. So for example, if we talk about the upper limb, the one at the shoulder and at the wrist contributes about 80% of the growth of the arm. whereas in the lower limb, it's around the knee where the bulk of the of the growth happens, as you can see over here. And so you can imagine that if you injure one of these more important growth plates, you're more likely to end up with some kind of problem in the longer term as you grow. The most common mechanisms of injuries are, number one, people falling from some heights, typically not their own height, but trampolines, monkey bars, these sorts of things, or road traffic accidents. And typically, if it is a road traffic accident, it is a car versus a pedestrian, because those are associated with higher energy, and also a limb which is probably planted on the ground, and therefore there's some resistance to movement at the time. Of course, like with any pediatric injury, non-accidental injury is always at the back of our minds. And in these, there are some very serious types of growth plate injuries, which are almost exclusively the consequence of non-accidental injury. We have a classification system to describe potential injuries to the growth plate. It's called the Salter-Harris classification. This is a diagrammatic representation of Salter-Harris fractures 1 to 5, where 1 is where you've got just a slip through the growth plate. 2 is it slips through the growth plate but then exits up the bone, 3 is when it exits down the bone, 4 is goes across, and 5, which is the most severe, is where it crushes the growth plate. And these are some x-rays representing cases 1, 2, 3, and 4. It's very difficult to see a 5 on an x-ray. But effectively what you can see here is that's just a slip there. This is a slip with a tiny fracture going up, as you can see here. This is a slip with a tiny fracture going down, as you can see there. And this is a 4 where it's gone right across. The growth plate itself is split into different areas. Obviously, the different areas are relevant, but one of the zones is called the hypertrophic zone, and the other important zone is the germinal zone. Basically, these are the areas where the cells in the growth plate are the biggest, and therefore it is easier for them to slip because the bonds between those cells are relatively weak compared to the size of the cells. What happens is if you do have an injury that damages either the hypertrophic or the germinal zone of the growth plate, you can end up with what's called a bony bar across the growth plate. That means that the growth plate stops working as a growth plate and lays down bone, and it then links the top end of the bone to the bottom end of the bone in a premature manner before that bone has finished growing. If you have a partial bar, so if only one side is tethered, one side will keep growing normally, whereas the other side won't, and that can result either in a what's called rotational problem or an angular problem. If you have a complete bar, or if it's the very middle of the growth plate which is censored, then you can get what's called a longitudinal growth arrest, which means the bone just stops growing at that bit, and that limb is shorter than the contralateral limb. As we said earlier, there are some sites which are higher risk, with the knee, so the distal femur and the proximal tibia being the most at risk. The ankle is also quite at risk, as is the wrist and the fingers. If we look over here, so this is a child, this x-ray here is a child who unfortunately must have sustained a very high energy injury through the growth plate of the distal femur, so just above the knee, and this bit of bone is completely gone to the wrong place. That child had it treated, but you can see the net effect is now years down the line that this right leg is shorter than the left leg. So this bone, this femur, has had a complete growth arrest, and therefore, whilst this one has kept growing normally, this one hasn't, and so the right leg is much shorter than the left, and the pelvis is tilted, whereas you can see that the shin bone, for example, which is relatively unaffected, is roughly the same size right to left. If there is a growth plate injury of any sort, there are principles that most and all orthopedic surgeons should adhere to in treating them. So number one, and this is key, is to treat the device with respect, because it's already been badly injured by the injury itself. What you don't want is to compound that injury with further trauma from surgery to try to make the problem better. So we talk about a very careful and gentle way to put the bone back into place to reduce the fracture. And a lot of it is about applying force in the line of the fracture rather than trying to push that bone back into place. As I said, you want to avoid repeated and forceful attempts to put the bone back into place. You also don't want to wait too long before you do that, because in children in particular, also in adults, but in children in particular, if you keep two bits of broken bone next to each other, that bone will heal, even if it's in completely the wrong position. It may not be functional and there may be pain, but the bone itself will heal. And in children, that healing happens much, much quicker. So if you wait 7 to 10 days from an injury, there is almost certainly early bone healing. And you may require more force to overcome that early bone healing and push that bit of bone back into place to hold it in the right position, and that can injure the growth plate. Also, as you can see here, for example, you want to make sure that the metalwork, which is this black screws here, is close to but not crossing the physis, the growth plate. So here you can see this child had again a distal femoral injury, so it's gone through the growth plate and come up. So it's what we call a Salter Harris 2. You can see the fracture line there. The bone has been put into place very nicely, and these two screws are holding the bone in place, and they are close to but not crossing the physis. That's really important. And the final point is maintaining that reduction. So you could push that bone into place. If you don't put metal in to hold it, or cast, or a combination of some kind of fixation on casts, that bone will just slip back out of place, and in doing so, re-injure the physis. So gentle, so you need to put the bone back into place gently, you need to hold it in the right way, and you need to then make sure it stays in that position. Once you've done that, it's really key to follow these children up properly. So as much as possible, we try to mobilize them early to keep the joint moving, because the joints and the bones like being moved. That's what they're made for. If, because of the configuration of the fracture, you do have to cross the physis, which happens in certain types of fractures, and it is completely acceptable to cross the physis in a proper way to treat it, you have to remove that metalwork early before there's time for a bar to form because of the metalwork that you have put into place. The most important thing is you need to keep a close eye on this growth plate and make sure that as the fracture heals and the child grows and the growth plate grows, you know it's growing in a proportionate manner in its entirety and not just partially as the child grows. And because we mentioned earlier that we know from evidence roughly at what rate the different growth plates grow and what the expected rate of growth is, you can by keeping a close eye on them, seeing them every few months, 6 to 12 months roughly, and for a few years after the injury, you can measure whether there is an angular or length arrest which is happening. If we're talking about the lower limb in particular, it's important to get weight-bearing X-rays, because sometimes putting weight through that limb can uncover a problem with the bone or the joint, which is otherwise hidden if you are not weight-bearing. Remember that our lower limbs are made to take weight, and therefore you want to assess the limbs, even with radiographs, in a weight-bearing manner. And we use special types of views called long leg axis alignment views to have an overall picture like those long leg X-rays I showed you before. The key thing is, if there is early development of any kind of asymmetry, whether it's angular, rotational, or length, you need to speak to someone like me, who's a pediatric orthopedic surgeon, who can advise on the treatment of this. There are things which people should pick up on when they are seeing children who've had growth plate injuries. Firstly, if looking at this X-ray as an orthopedic surgeon, I can see right away that there's a problem with this growth plate. So without knowing any injury, whether there was injury or not, something's not quite right with this growth plate, because the angle of the growth plate relative to the femur on both the views is different to what it should be. And this should precipitate further assessment with MRI and or CT scan. There are other special lines we can look for, something called the Harris growth arrest lines, which I will show you, and any obvious deformities like this child has here. This child is already getting deformity at the knee. These Harris growth arrest lines are really useful. Anytime that the body is put through any kind of stress, be it a fracture, illness, chemotherapy, whatever, the growth plate lays down an extra layer of bone. And that shows on X-rays. And so by looking at this line here, I can tell that this child has had an injury in the past, or something which has systemically affected the child or that bone. And same here. Now, because I know roughly the rate at which this growth plate grows, by measuring the distance from this line to this growth plate, I can estimate broadly how many months or years it's been since the injury. And that can serve as a very good prognosticator for any future deformity if there is going to be one. If you have a line which is perfectly parallel to the growth plate, then it's likely that the growth plate was injured in its entirety in the same way. And therefore, the risk of getting what's called an angular deformity, where only, say, half of the growth plate was affected, is low. But you may get a length deformity. If, on the other hand, like this one here, different bone, different patients, you have a growth arrest line which is not parallel to the growth plate. So here you can see that this line here and the growth plate are convergent. It means that whilst this part is growing normally, this part isn't. So this child is indeed at risk of getting an angular and a length deformity. It's also important to look at growth arrest when you have two neighboring bones. So in our forearm and in our leg, we have two bones, and normally they grow in a proportionate manner. This is someone's wrist. You can see here that this bone is significantly lower than this one. These should be at the same level. This tells me that there's been a growth arrest to the distal radius, and either this wasn't picked up on, that this was overgrowing, or it was missed. Same with the ankle, where you have two bones. You can see here that there's certainly been some sort of injury because there are screws there. And I know that the tip of this bone is far too high relative to the tip of this bone, and this bone is even bending. So there's certainly something going wrong, and there is a disproportionate amount of growth between neighboring bones. There are risk factors associated with higher rates of growth disturbance. Number one is the type of fracture. So we talked about Salter-Harris classification. We know that 5s and 4s are the most likely to cause growth arrest because they are typically the ones which are associated with the highest energy at the time of the injury, but also where it happens. We mentioned earlier on that the femur, for example, and the knee are less commonly injured than the wrist and the ankle, but they are more likely to develop growth arrest. And there's plenty of evidence to show that over the years. The other factors which play in, but which are less important, are the mechanism of the injury and the energy, the amount that the fracture initially was moved, and therefore how much it had to be moved back as well, the time to treatment and the type of treatment, whether it's put back in exactly the right position or just off, and how forceful that energy to reduce that fracture was. If there is a growth arrest, as I've mentioned, you could have a length, angular, or rotational abnormality, or a combination of all three. Broadly speaking, if you have a leg length difference, which is more than 2 centimeters, there may be problems with the way you walk. And if there's an upper limb difference of that much, it tends to affect you much less because our upper limbs are much more adaptable than our lower limbs. If I were to go down to any high street now and measure 100 people's legs, 10 of them would have a difference of up to 1 centimeter and wouldn't know about it. So that is normal. So we only really start to think about functional consequences if the difference is more than 2 centimeters. If you have an angular deformity or a length deformity or a rotation deformity, you can have abnormal joint biomechanics and therefore function, and this can result in early degenerative changes, and you could end up with arthritis, for example, at a younger age than you should. It might also affect your ability to participate in sports or employment later on, and of course there are psychosocial elements, things like bullying because of abnormally shaped limbs. The treatment of a confirmed growth arrest, so I'm not talking about the fractures here at the time of the injury, I'm talking once the initial injury has been treated, but subsequently the child has a growth arrest. Broadly speaking, there are 3 options. One is to complete the damage to the growth plate so that the damage doesn't get any worse. So you effectively press pause on the problem and stop it from getting any worse, and then deal with the sequelae of having a shorter limb, because there won't be any progressive deformity in an angular plane at that point at a later stage. The other option is to try to excise the bit of bone which has formed abnormally across the growth plate, and that's called a physeal bar resection. Broadly speaking, you can do that if less than half of the growth plate is affected, and if the child has about 2 years or more of growth left ahead of them. Finally, if the growth is completed, then you might need to do what's called a corrective osteotomy, which means you reshape that affected bone back to the way it should be and put metal plates and screws or nails to hold it in place. So if we look at these images here, this is some intraoperative images from a patient who has had a physeal bar excised from distal femur. And in that same patient, you can see that as part of the process, so this is where the physeal bar was excised, but as part of the process, they've also slowed down the growth on the unaffected side, so that the net effect is that by the time this child finished growing, the legs are roughly the same length. So there's a small difference. Some children do better than others. If you have a small bar, if you are a younger child, and if you have a central bar, you are more likely to do better. Also, if the reason you have a physeal bar is because you've had an injury, as opposed to having a bone or joint infection, then you are more likely to respond better to treatment and is more likely to work. I think that this is particularly important because whilst you may be seeing people who have had growth-based injuries as a consequence of an actual traumatic event, you may also be seeing people who unfortunately have been mismanaged, who might have been put through surgery to try, with all the best intention, to try to regain the growth and get things back on track. But if the bar was too big or they had not enough growth left, you shouldn't put the child through that surgery. Okay, let's talk briefly about the legal aspect, and then we'll talk about some cases. So when we talk about clinical negligence, obviously the duty of care aspect is established right off the bat by the doctor-patient relationship. There can be a breach of duty either in case of mismanaged growth-based injuries at the start, or more commonly, I suspect, missed injuries. So people who had an injury, the injury was picked up on, the injury at the time was probably sufficiently well managed, but no one picked up on the fact that this child was at risk of developing a growth arrest. And as we know, we need to measure this against the BOLAM test defined by BOLIFO. That's it. And in most pediatric orthopedic practices, if you have an injury of any sort, be it traumatic infection, whatever, around the growth plate, the expectation would be that that child is followed up for a certain number of months, if not at least a couple of years. Causation can sometimes be tricky because it can be difficult to differentiate between how much of the problem is caused by the actual initial injury, that means the fracture or whatever injury there was to the growth plate, and how much of it was caused by the subsequent treatment or lack thereof. And that can be very difficult to ascertain. We know certainly that if you have a fracture around the growth plate, you are at an increased risk of having a growth arrest. And even in children who are managed completely appropriately from start to finish, there is a risk. In those cases, it's very easy to attribute the causation to the actual injury because they were managed appropriately. If you add to an injury an element of less than ideal management, that can make things a bit more complicated. There are various aspects that often get put through the various experts for the claimants and for the defendant. Typically, it involves the early stages. That means failure to obtain the right imaging, or the right imaging has been obtained, but the interpretation has been wrong. And that normally sets the wrong tone for the remainder of treatment, because if you've not picked up on a potential growth plate injury and a potential growth arrest, you are unlikely to be appropriately followed up to make sure that even if you do get a consequence of your injury, that is appropriately managed. And therefore, early detection and appropriate treatment with referral to a pediatric orthopedic specialist is really important. If you do have a growth plate injury, it is likely you will need several surgeries. And I say surgeries because there is little role for non-operative treatment. If you have a small difference, let's say you have a growth plate injury, you have a leg length discrepancy, and it's going to be somewhere between 1 and 2 centimeters, you do have the option of treating that without any surgery and accepting you've got a post-traumatic leg length difference, and you can treat that with things like insoles and orthotics. But if you have anything more than that, or you have lots of growth left, the only way to treat this is with surgery. And correct me if I'm wrong, but I believe that the limitation in England and Wales is 3 years, which means in pediatric cases that takes you until the age of 21 at least. When it comes to quantifying the damage in growth plate injuries, often it's fairly straightforward. If you have an isolated growth plate injury which is appropriately managed, the fracture would have caused a growth plate injury, and were it not for the injury, they wouldn't have had any growth arrest. Quantum can be much harder to establish, like with all pediatric cases, because you need to establish what the prospective earning potential and life goals in general for that patient are, and that changes. How many of us now in adulthood have the same dreams and aspirations, or even fulfill our childhood dreams? Probably not many of us. And there are some things which are easy to quantify, and that, future medical costs, whether it's imaging, surgeries, physiotherapy, orthotics, time lost for parents because of because of appointments and surgeries, etc., travel and all that, and of course there is pain which has to be factored in as well. Generally, if you do have an injury that involves the growth plate, it does tend to come on slightly higher personal injury awards, and that's because there's a limited role for non-operative treatment, so by default you're probably looking at more involved treatment. The earlier and younger a child is injured, the more growth they have ahead of them, which means there's much more time for things to go wrong, which means possibly the need for many more interventions. An early injury of the physis can cause a cascade of surgeries where initially we try to maybe guide the growth, but that might not work, and only time will tell us if it is going to work. And so you try one method first. We talked about the 3 different options: guided growth, then you might need to do something more involved like a corrective osteotomy. And all of this results in lost school days, work days for parents, etc. And ultimately, it will potentially affect what the child can do, both from a hobby's point of view, but also from a profession point of view. There are various standards which are often cited in court. Of course, the number one would be the BOA and the BISCOS. It's a British Society for Children Orthopaedic Surgery Standards of Trauma Care. There are the NICE guidelines, including one specifically on fracture management in children. And of course, there are the Royal College of Radiologists imaging standards, which talk about, using cross-sectional imaging for the suspected injuries and how to follow them up. The role of the pediatric orthopedic expert is fairly straightforward. I would imagine you need someone who is trained in the management of pediatric bones, joints, and the physis to be able to not only give you a good assessment of the injury, but be able to give you a founded prognosis of where this is likely to end up, and therefore what treatment that child may need, and of course participate in various meetings with solicitors and joint experts, etc. Okay, I thought I'd go through a few cases. These are actually cases from both my clinical and my medical legal practice. So the first one is an 8-year-old girl who had several fractures to her forearm, always post-traumatic. There was never any concern for non-accidental injury. It started in 2018 when she was 2 years old. She had a forearm fracture, exceedingly common in a child of her age, very appropriately treated with a cast. Very soon after the cast came off, within about a month, she had another injury. I'll show you some x-rays. And then 2 years later, she had another injury, which was first managed non-operatively, and then they did surgery. And then age 6 in 2022, so now this is 4 years from the first injury, she was eventually, someone new to that department flagged that things weren't quite going to plan and hadn't been going to plan for the past 4 years, and she was referred on to me. So these are the x-rays from the time. So on the left, you can see that this child sustained a fall, and you can see that this is the wrist, the elbow is just here, this is the forearm. You can see there's a bend in the bone there, there's a slight bend in the bone there, and there's a break over there, which you can just about see there. And very appropriately, this child was treated with a cast, as would be standard practice in any center. The cast came off, and the child unfortunately broke the bone again. Again, we see this. There is an incidence of about 20 to 30% of early refracture in upper limb injuries, and that's because kids would be kids and they will fall again. The bone is slightly weaker, and in this child's case, that bone had a bit of a bend to it from the first fracture, and the bone hasn't yet had enough time to what's called remodel, because children's bones can remodel, which means as they grow, they can untwist and grow back to a much more normal shape. What was missed early on, I suspect, was that there was potentially something going wrong at the elbow, and we can already see now that there's a slight bend to the elbow joint and the growth plate just distal to the elbow. This child was put back into a cast and treated with that. And that fracture went on to heal, and you can see that because, as I mentioned earlier on, ultimately the bone doesn't care what position it's in. If the bones are in close proximity, in most cases they will heal. And this bone went on to heal. But again, you can see there's something not quite right there. You can see it again at the elbow there. A few years later, now 2 years down the line, the child fell again, and this time broke the arm again. And now you can see that that bend in the bone is still there. Now there is very clearly something wrong at the elbow joint, because this bone should be looking at this bone, and it's not. It's looking here, and you can see that both bones are broken again. And so this child initially had cast treatment and then converted to surgical treatment, but they only treated one of the bones and did not address the very significant bend in this bone, which is almost certainly a consequence of growth arrest at this physis and also abnormal fracture remodeling. So it's a combination of two things. And so this child was then in a situation where one of the bones had healed with this bar. Unfortunately, she fell again in 2022 and broke around this metal bar. And again, you can see this very abnormal bend in the bone there. And it was at this point that she was finally flagged and referred on to our service. So we got some cross-sectional imaging, as would be considered normal, and you can see that there's an abnormal angle in the bone. It's bent by about 30 degrees, and what's called the radiocapitellar joint, so part of the elbow joint is abnormal. And whereas this joint is normal there, and there are nice normal pressures across it, here you can see it's angled, and therefore this bit of bone doesn't have any pressure on it, and this bit of bone has all the pressure on it, and that is abnormal. And it's called point loading. And indeed, this child was having pain in the elbow, so away from where the fracture was, because of this point loading. And she had an abnormal range of movement. So that joint is very important to move the bones, but she couldn't. She was having pain. So she had a corrective surgery under my care, which involved fairly big surgery compared to what she'd had before, with reshaping of the affected bone, needing to cut the bone in 2 places, move all the really important nerves that control all the function in the hand, because they're all around the elbow, as well as the blood vessels, and put a metal plate and screws on to hold the bone in the right position, and undo all the work, all the changes that had come about as a consequence of the fractures. And I'm pleased to say that she did very well. The bone healed. So this is the early postoperative stage. You can still see the osteotomy, which is where I cut the bone healing, but she did exceptionally well. The bones are now both straight. The joint is now pointing at the elbow as it should. She was extremely happy, and eventually took the plates out, and this child's function is now near normal. Just before we go on to the next case, will you excuse me for 1 second?
Hi, everyone. Good afternoon. Whilst we take a very short recess for Mr. Mifsud, if you weren't here at the beginning, he has a bit of urgent things happening at home, so he has to take a couple of minutes out, but he'll be back with us in just a moment to continue on. And and he's already back. So
yeah,
here we go.
Sorry about that. Thank you very much, Leo. So that was the first case. Second case, so this is not a post-traumatic injury, but rather this is a child who has an infection, which involves a growth plate. So again, this is a child who had a bone infection, so osteomyelitis is the technical term for bone infection, but she also had what's called a septic hip, so that means an infection in the joints. And she presented to hospital with, pain in both hips and reduced range of movement, and she was really unwell, and she was started all the appropriate antibiotic treatments, etc. And part of the management involved surgery to wash out these infected hips. Also, the child is a very complex from a behavioral point of view, which made all aspects of her care quite tricky. She had several washouts, but despite that, the bone infection kept getting worse and worse. And the team in charge were unable to get on top of her bone infection, and that kept spreading throughout the bone of her thigh and also all the muscles around the hip and her hip joint itself. So she had several surgeries, I think, before she got to my care, probably about 7 surgeries. In the end, she unfortunately went on to suffer what's called a pathological fracture, which means that her left hip broke, which is an exceptionally rare and can be a devastating injury in a child of her age. So the right hip had recovered, the left hip had recovered reasonably well, but the right hip, unfortunately, was still, you can see the bone looks very different. And unfortunately, the bone broke, and you can see the break just there. She was then treated for that, and that management was initially non-operative with a cost, which is contentious, but probably was not the ideal care for what's known as an intracapsular fracture. That didn't work, so she then went on to have another operation to try to get the bone to heal. So there you can see the bone is still broken, but she had an operation to try to realign the forces across the hip joint to see whether that would cause the fracture to heal, but unfortunately it didn't. And at that point, she was referred to my care, and I was involved in her case. And so we got some cross-sectional imaging, as always, CT scan, MRI, and you can see here that that bone still hasn't healed, and there are changes within the bone to show that there is active infection going on. So took her through a complex case MDT with other surgical colleagues, but also with my bone infection colleagues. And ultimately, I took her to theatre for a fairly complex operation where I undid what had been done with the previous surgery, made the hip back to the shape it should be, took away all the infected bone, and put loads of metal into the right place to hold it all in place, and included one procedure called the surgical dislocation of the hip, which is a fairly complex procedure where we try to treat injuries of the head and the neck. And she's done very well. So because things are now back to normal as they should be from an anatomical point of view, and because all the infected bone, etc., has been taken away, she has done very well, and she's back to tap dancing. The hip is now starting to grow again, and she's got a very good range of movement. I'll just present one final case before I take questions. So this is a child, so a normal hip, as you've seen from the previous case, should look something like this. This is a child who has growth plate injury to the head, not because of trauma or because of infection, but because of a condition called Perthes disease, which is a fairly common condition where for some reason, we don't really understand why, the growth plate of the femoral head, which is the ball of the hip joint, the ball and socket joint, stops growing. And you can end up with quite marked deformities at your hip. And indeed, that can result in early arthritis and very long-term functional consequences to that. So this child was being followed up for a long time, was always being told, well, at this point, a young adult, told there's nothing you can do. We will have to do a hip replacement at a young age, which is not altogether an unreasonable option. But with further investigation, there was the option for a reconstructive option, which would allow the patient to keep their own hip and prevent them needing a hip replacement at a very young age, which is what they had. They had a reconstructive option around the right hip, which they are very happy with, and eventually they want the left side done as well. And whilst this undoubtedly does not cure the hip, but it certainly will push the need for hip replacement further into that person's future and allow them to maintain their day-to-day activities and work for much longer because they don't have an artificial joint. Okay, that's it from my point of view. I've gone through some cases of growth plate injury of various types. Hopefully, I've managed to explain a bit about growth plates, and I'll be delighted to take some questions. I'll just stop sharing my screen.
It's fine if you just leave it on. It's absolutely fine.
Okay.
We'll leave that up.
Okay.
Just before we jump into any questions, obviously the Q&A function's at the top. Please feel free to pop in some questions. I want to just very quickly take the opportunity to mention our next event, where we're hosting actually a live podcast in Bristol on the 17th of July in collaboration with St. John's Chambers in Bristol. We'll be focusing on mild traumatic brain injury. So this will be an event which you can access live in Bristol, or alternatively, you can also sign up to watch on the webinar. So please feel free to do. And actually, thank you very much, Mr. Mifsud, Max. Thank you very much for that. That was very, very, very interesting. And one question which did occur to me as I was just listening to you then was, do you think there's enough general awareness among non-specialists about the long-term risks of growth plate injuries? Or do you think that many of these issues are missed because they're just not on the radar?
Yeah, I think that is undoubtedly a big part of the problem. So, whilst I think that certainly with pediatric orthopedic surgeons, it's obviously well in their minds, and probably with most orthopedic surgeons, they will think of it, even if they might not, understand the nuances of how to manage it, which I wouldn't expect them to because they're not pediatric orthopedic surgeons. It would certainly be on their mind. I think the biggest issue is with these children who have fairly innocuous injuries and might simply be seen in an A&E department, have an injury, put a cast or maybe just given a splint and discharge without any appropriate follow-up. So certainly one thing which we try to do, as part of CPD events and all that, is to make sure that primary care and emergency care physicians are aware that if you have an injury around the growth plate, there is a risk of having a growth threat, and they should probably be seen by a pediatric orthopedic surgeon at some point, even if it's just a reassure and discharge.
No,
And I think
that's
a lack
very
of awareness is definitely a key point.
no, that's very, very good. And I know you mentioned, just to follow on to that, is if a child is not referred for over a week, which obviously you said is one of the key times, what signs in the records might indicate whether that delay has likely impacted the final outcome?
Yeah, so I think if these sorts of cases aren't discussed, early on, anything within the records to say, has injury to the growth plate even been commented on? Has anything been noted in the notes, whether the radiology reports or the clinical notes or the outpatient notes, to say, look, this is for example, Salter Harris 2 injury, to at least show that there's some awareness that there's a growth plate involvement. And I think if there is no mention at all, then that is of concern. Recently, I was involved with a case. It wasn't a growth plate injury, but it was a child who broke their femur, their thigh bone. And one of the issues is, has the rotation been put back into the right place when they treated this child? And there wasn't a single mention of that. And, unfortunately, there was actually a mention. They commented on other problems and didn't act on them, but didn't mention this, which is a key point. And I think that is, that's always very important in the notes.
No, absolutely. And just from my side, again, as we're talking about notes, are there any particular red flags that the solicitors could look for within the notes of their own cases, which might highlight that some of these potential issues you've discussed are about to appear or could be likely, and therefore know to reach out to you or obviously other paediatric
colleagues?
surgeons?
Yes, of course. Yes, so I think anything that mentions, a high energy injury around a joint, and most especially if it is the knee or the ankle, which we know are the ones where growth arrest tends to happen, or around the wrist. I think anything which is high energy, anything which mentions the word growth plate, I think there has to be awareness that long-term follow-up and referral to a specialist is really important.
No, brilliant. Thank you for that. We've just got a question here from Rebecca Anderson. Appreciating all cases are unique, do you have a rule of thumb for how long you would generally allow to assess long-term condition and prognosis in cases of this nature?
Yes, thank you, Rebecca, first of all. So because we know the rate at which the different growth plates grow, some will show you a problem pretty early on. So for example, if we talk about the distal femur, so just above the knee, that growth plate is the one that grows amongst the fastest in the body. It grows at 9 millimeters per year, which means even within a year, you should be able to see a problem because you can see something which is 1 centimeter on an x-ray. But for example, if we're talking about the hip, that top end of the ball only grows at 3 millimeters a year, and it's the same for the ankle. So that can be much more nuanced. As a very broad rule of thumb, I would say you need to follow people for at least 2 years after a traumatic injury or a bone infection which has involved the growth plates to ensure that there isn't some sort of growth arrest. And I think anything less than 6 months is impossible to know.
Thank you. I've just seen that Ian has put his hand up. I don't know if that was on purpose or not, but if he has a question, pop it in the Q&A now or the chat function and we can ask it. However, if people have any specific questions that they may wish to ask relating to their cases, then obviously Mr. Mifsud is available to answer case-specific questions for you on any of your legal matters moving forward. Well, I'm not sure if there is any other immediate questions. So let me take the opportunity again to really thank you for your time today. We really appreciate it, and it was a very interesting lecture and presentation to us. And I'm sure I speak on behalf of everyone here when I say that. So thank you very much, everyone, for attending again. Wishing you a very good day and rest of week, and looking forward to seeing you at our follow-up next event. Thank you very much again.